All right, next up we have Dr. Samuel Shor talking about patient advocacy.
Actually, I'll be talking about scientific issues in Lyme disease. I want to thank the organizers of this event, Josh Cutler and others, and appreciate the opportunity to speak before you. I'm a primary care internal medicine trained clinician who, through my interest in chronic fatigue over the years, have kind of backdoored into this whole Lyme arena and present to you today as chair of the Loudoun County Lyme Commission and member of the Virginia Governor's Task Force on Lyme disease, what my perceptions have been over the last several years. About 10 years or so ago, 2003, I published a paper on chronic fatigue syndrome. And chronic fatigue syndrome is defined as a condition of severe fatigue such that an individual is incapacitated to a degree less than 50% of their functionality as to where they were prior to becoming ill. A duration of at least 6 months, such that other causes of fatigue have been ruled out. And there's the bugaboo about that diagnosis because there are no diagnostic markers. It's a diagnosis of exclusion. And that in the paper that I published in 2003, I discussed, among other things, how a majority of patients present with a myriad of other symptoms which you're probably all familiar, such as fractured non-restorative sleep, blood pressure issues we call dysautonomia or autonomic dysfunction, such as NMH or POTS, cognitive impairment, mood abnormalities, hormone problems, etc. But around 2003, I began hearing about these folks who had Lyme disease presenting as chronic fatigue and began to explore in my attempt to better manage my very complex patients. And one thing led to another, and I began to realize, in fact, that the powers that be, the IDSA, the CDC, etc., have been promoting a diagnostic strategy called the two-tier system that is profoundly flawed. And it's already been mentioned by the previous speakers that under the best of circumstances, on average, this may be 50% sensitive, so that a clinician in good faith may feel that a patient is coming to their office and think that Lyme disease is a serious consideration. They get a test, and every other patient under those circumstances may be told they don't have Lyme disease, which is obviously totally unacceptable. So that when we say Lyme disease, we generally mean certainly classically the infection due to the organism Borrelia burgdorferi, but most in the Lyme community, if you will, recognize that it's Borrelia and co-infection. So it's a very complex multi-system process. And that this two-tiered system is totally inadequate. In fact, one of the statements coming out of the position statement of the Virginia Governor's Task Force was that there is no blood test that can rule out Lyme disease. So here you have a complex called chronic fatigue syndrome that requires other problems to be ruled out, and you have a condition, Lyme disease, that has all the potential to create those symptoms but can't be ruled out. And there is then the problem. And soon after 2003, I began looking at my chronic fatigue syndrome patients and with a different realization that, in fact, they may have blood test negative Lyme, and began exploring other alternative diagnostic criteria using IGeneX and other testing systems, such that I began exploring that a good number of my patients actually I felt had blood test negative Lyme, and began treating them with prolonged antibiotics in a directed, carefully supervised manner. But to give you an example, I had a 42-year-old gentleman who presented with a 2-year disability, wanted to work. He was a lawyer. He was so frustrated, but he had, for all intents and purposes, the diagnosis of chronic fatigue syndrome. But in further evaluating him, to which I alluded, recognizing by history he spent much time outdoors in Northern Virginia, endemic to Lyme disease, the blood tests that we got suggested with the highly specific bands that, in fact, he may have Lyme. So what will hurt him to try this antibiotic regimen? And as it turns out, slowly but surely, he started to get better. And 15 months later, he's working full-time. And this was because of the change in paradigm with respect to the insights of looking for more creative ways to diagnose Lyme disease. I began more aggressively evaluating all of my chronic fatigue syndrome patients with that in mind, and began seeing incredible changes in terms of benefits therapeutically, gains that I would never have achieved with just treating them without that Lyme reality. And subsequently, in 2011, 2 years ago, I published in peer review an analysis of my database, and I analyzed 210 patients in my practice that fulfilled criteria for chronic fatigue syndrome. And that had to include a negative blood test for Lyme disease, according to the IDCA and CDC. I then looked for secondary markers, a highly specific band, the presence of a co-infection, recognizing that Lyme is the #1 tick-borne disease in the United States. And if any of those criteria were met, I included them in my highly suspicious for Lyme disease. And of my 210 patients, guess how many had highly suspicious markers? 209, 99%. I then treated them aggressively with antibiotics and tried to track them with a metric that I generated. It's a symptom questionnaire that graded by number the degree that at any given point in time their symptoms were rated on a scale of 0 to 3, fatigue, pain, etc. And over time I was able to determine how well people were responding under those circumstances. And at the end of the day, in my final published report in peer review, I determined that 62% of the 209 patients had statistically significant improvement with antibiotics. 62% of my chronic fatigue syndrome patients had Lyme disease. And a number about 26% clinically improved but just didn't reach statistical significance. So that I believe in this paper in peer review that we were able to support not only the diagnosis of chronic fatigue syndrome, a number being due to Lyme, that chronic Lyme disease in fact does exist, that it is treatable, that it represents a chronic infection that is amenable to antibiotic therapy, and that it's a chronic relapsing condition. One other series in relation to scientific advances, another area of interest that I've evolved in my attempt to provide my patients with expanding options is something called hyperbaric oxygen treatment. And we've opened a center just across the river in relation to a study that William Fife in 1998 published, looking at over 70 patients with Lyme disease, that without antibiotics and using this technology of hyperbaric oxygen, he was able to show significant clinical improvement. Hyperbaric oxygen represents a treatment strategy of introducing 100% oxygen under pressure, and that has the ability, among other things, to improve immune function and under certain circumstances actually kill the infection. And so that is another strategy that we're employing under certain circumstances. So in closing, I'd like to reiterate the fact that a large proportion of my patients in Lyme endemic Northern Virginia with, quote, chronic fatigue syndrome actually had seronegative or blood test negative Lyme disease. That chronic Lyme disease does, in fact, exist, and that if it weren't for the Lyme advocacy supporters such as yourselves, we wouldn't be able to generate the legislation that's been discussed, that we wouldn't be able to move this process forward. And I am absolutely convinced that we are far better today than we were a year ago because of your support. Thank you.